Well, it's 12 o'clock now, and I think we can go ahead and get started. It is my great pleasure to welcome you to our last CPPI seminar of the year, if I'm not mistaken, for sure before Thanksgiving. I hope everyone is excited and getting their stretchy pants ready for Thanksgiving. We still got to celebrate, even though we're in the midst of a pandemic. So let's just do the best we can. It is my great pleasure to welcome Dr. Anika Hines to our monthly seminar. Dr. Hines is an assistant professor in the Department of Health Behavior and Policy here at the VCU School of Medicine. She holds a PhD in Health and Public Policy from Johns Hopkins Bloomberg School of Public Health, an MPH in Health Policy and Administration from Yale University, and a bachelor's degree in biological sciences from Hampton University Honors College. Upon graduation from Johns Hopkins General Internal Medicine Research Fellowship, she was awarded with the 2018 Fatemeh Vahabzadeh Award, very hard to pronounce this one, for her research. And her research interests are around health equity, focused on chronic stress within the context of neighborhoods and the broader social environment. Prior to her career as an academician, she worked in industry, serving as a consultant to federal health agencies and health systems on public reporting of healthcare quality, disparities, cultural competence, and health equity. She uses a multidisciplinary approach and community-based participatory methods to understand mechanisms that underlie chronic disease progression among racial and ethnic minorities, to identify modifiable targets for intervention, and to design, implement responsive, multi-level, evidence-based strategies to eliminate health disparities. So please join me in welcoming Dr. Hines to our seminar, and welcome. We look forward to hearing your presentation, Dr. Hines.
Well, thank you so much for that introduction. I'm so happy to be with you all today. I am going to be talking to you. I put up this claiming CE credit up, and I'll put it up again at the end of the presentation. But I'm going to talk to you today about kind of clinic community partnerships in addressing health disparities. And specifically, my work focuses on what we can do about with regards to preventive heart care, to address health equity. And so we're going to talk about blood pressure control and management today. And here I've outlined some objectives of this talk. One, we're going to review some changes in healthcare delivery regarding blood pressure control that will likely impact your practices, describe current trends in blood pressure management as they relate to interpersonal collaborations and strategies, discuss practice innovations designed to improve blood pressure control and to decrease health disparities in particular. And then we're going to talk a little bit about roles of pharmacists in these kind of interpersonal teams as we move forward in trying to improve blood pressure control and to achieve health equity. And so this as an overview, everyone here is probably pretty well versed in hypertension, but just in case that you're not, about half of US adults with uncontrolled hypertension have a blood pressure of 140/90 or higher. And this includes 37 million people. 70% of US adults age 65 and older have high blood pressure. About 30 million adults who are recommended to take medication. Almost 2/3 of that group have a blood pressure of 140/90. A greater percentage of men versus women have high blood pressure, 47 versus 43%. And high blood pressure is a primary contributing cause of death, and which is why I focus my efforts on preventive heart care and hypertension in particular, because it has so many potential impacts on or consequences with regards to chronic kidney disease, for instance, or also cardiovascular disease, other cardiovascular related diseases. The high blood pressure costs of within the United States are more than $131 billion per year. And so if we could really address hypertension and get people's blood pressure under control, not only could we avert millions of future cardiovascular disease cases, but we could also save a lot of money from with regards to the health system. And pharmacists can play a great role in that. This is just an overview. I wanted to just bring to your attention that, of course, the prevalence of hypertension when we're talking about adults 20 and older, there's a huge concentration of hypertension in the southeast of the United States, including in Virginia. Now, we don't have the worst of worst with regards to hypertension, but you see we're still a light red, the 30 to 30.1 to 31.9% prevalence of hypertension in the state of Virginia. And so this is particularly an issue, important to our region. We're not, exactly in that stroke belt with those dark numbers, but there are definitely opportunities for, Virginians to improve their blood pressure control. And I'll add that all of this information is available at the CDC, through the CDC. So I want to present now our first question, and I'll look at the gallery because I don't have the poll in operation. But what are the updated HAACC guidelines for diagnosis of hypertension 1 in adults? And I suppose you can kind of use the chat, kind of answer in the chat and see. Is it A, 140 over 90, B, 130 milligrams of mercury systolic, and 80 millimeters of mercury diastolic? Is it C, 130 or 80, or is it D, none of the above? So let me go to the chat and see if we have any responses there. Okay, so we have quite a few A's and at least one D. Some organizations use A or C. And so I'll tell you guys that actually A, C, so it depends on the patient population. That's a good answer. So I'm going to just move, sorry, my D. Okay, I'm trying to forward my slides here. Okay, so according to the ACC, granted there are special kind of recommendations for pregnant women. For instance, the kind of ACOG has specifics that they kind of deal with, under the condition of pregnancy. But these are the guidelines that AHA-ACC put out with regards to in 2017 with regards to the general adult population. So you see a normal systolic blood pressure would be less than 120, which and a diastolic less than 80. An elevated blood pressure would be considered 120 to 129, and less than 80. And hypertension stage 1 is actually 130 to 139 milligrams of mercury systolic, or 80 to 89 milligrams of mercury diastolic. And then stage 2 is what many of us have kind of worked with, that 140 over 90 as being, which is now considered hypertension stage 2 and not 1 according to these guidelines. Of course, there are some intricacies in managing special populations. For instance, individuals with chronic kidney disease may have a little bit of a lower kind of, they were already working with trying to lower people through the to the 130 over 80 range. But so for those of you who answered C, you are correct. These slides are sticking. Sorry, I'm having trouble advancing my slides. So I'm gonna exit for a second. Okay, There we are, we're back. So hypertension prevalence under the new guidelines, actually 45% or half of US adults have hypertension as defined by this 130 milligrams of mercury or systolic, or 80 milligrams of mercury diastolic. And the age adjusted prevalence is actually 48.6%. So now I'm going to ask you, what percentage of individuals with hypertension currently have their blood pressure under control in the US? Is it 60%? Is it 45%? Is it 30%? Is it 25%? B, C, B. So it seems like most have responded, okay, B, C. Most have responded either B or C. I saw at least one D in there. But we're looking at, we're really looking at prevalent, kind of control at the 45% area. And of course, there's variation in that by race ethnicity. Various populations have lower control. For instance, African Americans have, blood pressure control in the closer to 30% range. And so here's a recent paper by Paul Muntner and colleagues using the Hines data that actually shows that blood pressure control over time has actually, it was increasing from 1999 all the way up until about 2013, and since has begun to decline. And so you see that we're actually trending in the wrong direction with regards to blood pressure control. And this is a particularly, which makes this area of particular importance given all the consequences that I spoke of before. But in the second graph, we see blood pressure control among adults taking antihypertensive medication. And so the first graph actually includes individuals who are taking hypertensive medication or who might also be on some sort of lifestyle modification. But when we look at individuals who are taking antihypertensive medication particularly, there's also a decline there. And I think that is really important with regards to pharmacists who work with educating individuals in the context of their blood pressure control. And so we see that this is not just among individuals who might not be engaging with medication therapies, but also individuals who are, actually using medication therapies, which we usually see better control among those who are on medication. And so I want to talk a little bit about racial and ethnic disparities in hypertension. So we know that African Americans have, higher rates of hypertension, poorer control, and earlier onset than as compared to whites. And this just shows that, with regards to, this is actually from Hines, this is a CDC infographic looking at hypertension. And this is some older data, but the trends remain the same. When we look at percentage of non-institutionalized US adults with hypertension, the estimated percentage of individuals who are aware of, are treated for, or are in control of hypertension by sex, race, ethnicity, and age group, we see great variation there. And so these data, like I mentioned, are from 2002, but we haven't seen much change with regards to these rates of control, even though prevalence of hypertension has kind of changed over time. And so, for instance, we see that among, with regards to awareness, even though African Americans are, 70% of African Americans are aware of their hypertension, fewer have it under current treatment, and even fewer have it under control. And the same when you look at, Mexican Americans, you see, in addition, there are, about 50% or 49% are aware of the condition, but much lower rates of treatment and control. And as you can see, there's also among whites, lower treatment and control, but those levels of treatment and control, for instance, with regards to treatment, they actually have lower levels of treatment, but high, equal levels of control as African Americans, for instance. And so this brings us to ideas about approaches to improving health equity and control. So what are some approaches for improving health hypertension control and improving health equity, community engagement, team-based approaches, systems levels interventions, both A and B, all of the above. I'm going to go to the chat and see if we have any responses. And of course, you're all right. This was, an easy question. But, so all of these above, we need to be using community engagement, which, community pharmacists are particularly important in that regard. And I'll tell you a little bit about some of the approaches that, and some of the work has been done in that area. But, also these team-based approaches, and everyone plays a role from social workers to, of course, PCPs, nurse practitioners, nurse case managers, pharmacists, so on and so forth, and even community health workers. And then, the idea that, behaviors don't happen in a vacuum, they happen within the context of systems, both providers as well as patients. These are, multi-level, including systems levels interventions. And so here are some of CDC's recommended actions to reduce health disparities as it pertains to blood pressure. Increase community awareness of disparities as persistent problems. Set priorities among disparities to be addressed at federal, state, tribal, and local levels. Articulate valid reasons to expend resources to reduce and ultimately eliminate priority disparities. And so in that regard, the idea that clinics can work with community partnerships to actually improve follow-up and medication adherence, has been shown to be a strategy that might be particularly useful in this area. Then implement the dual strategy of universal and targeted intervention strategies. So, we know that blood pressure control is important for everyone. We also know that there are certain sectors of the population that might require additional, more intensive efforts to achieve that control. And so we're talking about a combination of factors. And then finally, aim to achieve a faster rate of improvement among vulnerable groups by additional, support needed to commit to closing the gaps, including allocating resources. So now I'm going to talk about a few studies that I've been involved in targeting blood pressure control. And, it's I have quite a few interventions to kind of go through and mainly just talk about kind of what the setup was, who were the key role players, and then what, outcomes they were able to achieve. And so in this first intervention is called the Achieving Control Together study, which was PI'd by Ebony Boulware, who is now at Duke University, who was at the time at Johns Hopkins University. And the intervention actually included African-American patients with uncontrolled hypertension, receiving healthcare in an urban primary care clinic, who were randomly assigned to receive one, either an educational intervention led by a community health worker alone, two, a community health worker intervention plus a patient and family communication activation intervention, that is the Do My Part intervention, or the community health worker intervention plus a problem solving component, and we'll call that problem solving. And so basically, this study found that BP control actually improved for all groups from baseline to 12 months, from 36% control to about 52% control, with significant declines in both systolic and diastolic blood pressure for all three arms. And for the CHW arm, kind of 9 points decrease. For, Do My Part, 7 points decrease, and the problem solving, 11 points decrease. And then also you see the decreases in about 4 to 5 milligrams of mercury for each of those interventions. And I'll just say, I'm happy to receive questions in the chat if you all have questions. So please feel free as I go through to ask questions in the chat if that is helpful to you. Okay. So next, I want to tell you a little bit about reducing any inequities in care of hypertension, lifestyle improvement for everyone, or the Rich Life study, which is PI'd by Drs. Lisa Cooper and Drs. Joe Marsteller, and I'm a co-investigator on this work. And so Rich Life is actually a 2-arm cluster randomized trial for improving blood pressure control and patient activation among a diverse population of individuals, about 1,800 individuals in the Maryland and Pennsylvania area, Maryland, DC, and Pennsylvania areas. And so Rich Life was comprised of 2 separate arms. One is the standard of care plus arm, which includes enhanced education, care management, and otherwise usual source of care. And then there's this interesting component called the collaborative care, stepped care component. And so Dr. Cooper in her previous work had found that in interventions for cardiovascular disease that were targeted at disparities, we will actually find that white patients would still do better than Black patients, even though everyone would improve. And so the idea, and to CDC's points about kind of allocating resources specifically to sectors of the population that we might be most vulnerable, is step up intervention through the nurse case manager actually provided additional engagement with a community health worker or a cardiologist or other specialists as needed to help to address some of the factors that might afford kind of more intensive care for the patients that really needed it. And so the primary outcomes of the study, which just concluded this fall, so we don't have the results just yet, we'll be looking at blood pressure control at 12 months, as well as self-reported patient activation at 12 months. But I will present, with this theme of trying to understand barriers that patients might encounter within the context of trying to improve their blood pressure. I wanted to share some work from another study within the context of Rich Life. And I'm sorry, I have to exit, it seems, every time that I look at the chat. So. We actually examined the association of psychosocial stressors within the with medication adherence in Rich Life. And we found that, perceived stress and discrimination for non-white patients, for Black patients, and, discrimination for Latino Hispanic patients in particular were associated with lower odds of medication adherence. And so I show this to say that when in thinking about the way that we approach patients and the educational components, there's a real opportunity to address these issues of psychosocial stressors and lived experiences that might impact barriers to achieving blood pressure control among, minority populations. And I think there's an opportunity for many community-facing practitioners to engage in education and so on that would potentially impact some of these challenges unique to these groups. And so the main findings were that, kind of using the social determinants of health framework, we identified associations between stress, everyday discrimination, and medication adherence among non-Hispanic Blacks and Hispanics that were independent of health status and other social determinants. So these are not about emotional support, not about education, not about income or, other kind of social demographics. They were specific to, because we adjust for all of those things in the model. These challenges were specific to their social status as racial and ethnic minorities, the challenges they face there, as well as, kind of self-perceived stress. And so programs to enhance self-management of African-American and Latino patients with uncontrolled blood pressure should include a specific focus on addressing social stressors. And so next up is the 5+ for kidneys, 5+ nuts and beans for kidneys, which is a primary, the primary objective was to assess the impact of a community-based dietary intervention on kidney damage reduction and blood pressure control among sociologically disadvantaged African Americans with chronic kidney disease and hypertension. And the PIs are Dr. Deidre Cruz and Dr. Pete Miller. And, just to give you a background, Baltimore, Maryland is both a food desert, meaning it has low access to high quality food, healthy food, as well as a food swamp. So, high access to unhealthy food products. And so, I actually performed, an ancillary study to this work where, and I'll just mention here the aims with regards to the RCT. There was one arm that was the usual care and another arm that involved coaching. And so the coaching to adopt the DASH diet alongside the 30, each of the arms were provided $30 per week to access, kind of potassium-rich foods. One received kind of education about what they should do. Another received intensive coaching, as well as assistance in actually ordering the food that they would then pick up at a community partner in order to, assess, to consume. And then we would assess, for instance, their urinary albumin excretion, as well as their blood pressure control. And so BP reduction is a secondary outcome. Again, this work is underway, and so we don't have results just yet. But the pilot study prior to this actually had an impact on hypertension, which is why, which had an impact on kidney function, but it was targeted at hypertension. And so because it was not effective with regards to hypertension as we thought it would be, I proposed an ancillary study that would actually look at psychosocial factors and the impact on the primary study outcomes. But in addition to that, I am also examining the food environment. And so my ancillary study provides a critical psychosocial component to the parent study and explain variation in outcomes of the intervention and to contribute to other population applications. Again, addressing these issues of social determinants and psychosocial stress that might be specific to these populations that disproportionately suffer from hypertension and have poor hypertension control. And so, in addition to that, because that work is still being collected, that data is still being collected with regards to the parent study, they're still recruiting, but, there is this ancillary component that was a photo voice project that examined the food environment. It included 22 residents of Baltimore who were 21 years or older, who self-identified as African American or Black, or who were hypertensive. And these individuals were folks who were initially screened but deemed ineligible for the parent study, perhaps related to their kidney functioning at baseline, which would sort of interfere with any potential assessment we could make of the impact of the intervention on those outcomes. And so individuals in this photo voice study were actually given basic photography skills and asked to respond to the statement, photograph everything related to food in your environment in images, and then participated in small groups over 4 sessions where they discussed these pictures. And so, kind of as an overview, the mean age was 65 years. They were mostly female, 41% had high school education or more. About 60% had less than $25,000 per year in annual income, and 50% were retired. 91% were insured. But these individuals participated in 8 groups of 3 to 4 members. The 22 were divided in 8 groups of 3 to 4 members, and participants made over 1,000 photographs in this process. And so we analyzed these findings, these photographs for thematic findings, and we found that the individuals actually constructed the food environment as a product of social injustice and racism and classism related to housing, education, municipal services, employment, zoning ordinances, taxes. And this actually led to a certain sense of mistrust that also contributed to their impressions of the food environment, including their leadership, but also, whether or not they trusted institutional entities and the food itself, like, whether concerned with whether or not the organic food was really organic, if GMOs were being, pumped into their neighborhoods to make them unhealthy, and what GMOs were and what their value were, and so on and so forth. And so there were these structural components in terms of availability of stores and healthy products, but also quality and presentation of products, oversaturation of unhealthy foods and products, and then these interpersonal components with regards to discrimination in the stores, and then internalized attitudes towards health behaviors. And all of these had generational effects on health behaviors, role modeling, and social mobility, which contributed more to, the mistrust. And the social programs designed, even though there were some that were positive, the ill-fitted programs, for instance, some of the food benefit programs that would cut, a working mother's, food stamps from $700 to $100 per month if she earned a certain amount of money, even though with no regard to how long she worked for that long, actually created a further social injustice, as participants said, and could actually contribute to ideas of mistrust. And so they also propose some community-based asset approaches with regards to community growing businesses, community collaboratives, representation in food, community representation in zoning matters, as well as business funding for community residents, which could address, these various issues. And so I just wanted to share this because I think that, as we move forward and we're moving, we're understanding that there's health in all policies, and that healthcare extends beyond the healthcare setting. We're really thinking about cultivating environments that include multiple entities. And I'll tell you a little bit more about a particular intervention that I'm launching right at VCU that really are opportunities for non-PCPs to really become involved in, addressing some of the social determinants of health that that disproportionately disadvantage certain proportions of the population and contribute to health disparities. And so I just want to show some of the thematic findings just briefly. I know we don't have a lot of time, so I couldn't go through all of this, but with regards to social injustice, one quote says, if they got a lot of processed food, that's killing us. Or another said, if you look at the fruits and vegetables, and this picture is actually from a state fair, everyone should be able to have fruits and vegetables that look this fabulous, and you should be able to eat them most nights. And with regards to community-based, community asset-based approaches, they say, like one of the brothers who comes to the program, he grows his own food. We have the talent and the skill to kind of do this for our own communities. And, we're going to survive regardless, but I just want more for us in talking about advocacy and civic engagement. So in thinking about how we can really activate patients in their own care, and how community resources can actually be supportive to these sorts of things are the reasons that I've shown these findings, in hopes that we can really start thinking about creative ways that perhaps within our professional capacities we can engage with our communities in a way that's supportive of their health. Right. And so now I'm going to turn back to a little more within clinic concerns. And some of the work that I've been doing is focused specifically on preventive heart care for young adults. Because, the risk calculators that are used often exclude individuals 18 to 39, which is problematic, particularly from my perspective. I'm saying this from my perspective because, when we know that African Americans in particular have earlier onset of hypertension, before they make it to the risk calculator, early intervention would actually be useful. So the NQA actually estimates that there's a performance gap between 36 to 43% for controlling high blood pressure among adults 18 to 85 years with a diagnosis of hypertension. So knowing that control is even worse among young adults, if you remember the slide I showed earlier, control among young adults is more like 20%. And so in thinking about, trying to achieve 100% control among individuals who have hypertension, we really have to think about approaches that will mitigate this risk by, one, getting young adults into treatment and perhaps raising awareness, but also thinking about unique ways and challenges, to the young adult population. For instance, many practitioners don't feel comfortable or, and rightfully so, prescribing medication to young adults to manage hypertension, at such a young age. So you'll find that lifestyle modification, and like, again, appropriately so, is, the likely mechanism that individuals might prescribe with regards to treatment of hypertension in young adults. And I just show here that, the performance gap could avert, millions, 46 million cases of, myocardial infarction, stroke, and heart failure if we could address blood pressure control among young adults. Which brings me to the PACE study, which is a patient-centered care for health equity, which is a pilot that I'm launching. It's a patient-centered, patient-activated approach and a community intervention, including home-based blood pressure monitoring, interface with a community health worker at the VCU Health Hub for hypertension education and referrals to primary care for abnormal readings, as well as interface with primary care clinicians who will review patterns of abnormal blood pressure readings with patients and discuss options for treatment as appropriate. And so we're actually doing some feasibility work because, even though we're saying, these roles will be assigned to PCPs and these roles will be assigned to CHWs, there might be opportunities to involve and engage with other team members. And so we'll be exploring facilitators and barriers from both providers' perspectives as well as PCPs with regards to how we can create an easy workflow with regards to, kind of getting young adults into care, helping them to self-monitor, and then, getting that information fed back to the primary care setting and coordinating accordingly with pharmacists, or CHWs who would provide, kind of some of the existing education, or nurse case managers or whomever that might be, in order to facilitate, this process. And so the primary outcomes of this pilot are feasibility, acceptability, preliminary efficacy, and achieving blood pressure control and patient activation at 4 months. And so I wanted to kind of briefly stop. I've said a lot. I wanted to briefly stop for a point of discussion, which are, what are some barriers that you perceive in your roles to improving blood pressure control among young adults? And so I'll take a look at the chat. So I'll give you a few seconds to think about that. Obesity is an asymptomatic disease. Compliance. And what are some, so from your perspective with regards to what levers you feel that you have, what could facilitate blood pressure control among young adults? Education. Education to whom? Education to providers, education to patients, emphasizing lifestyle interventions, socioeconomics, both. Everyone, educate everyone, do all the things. And so, that would be social determinants of health. No, all of these are important answers. You have encapsulated the barriers. It's an asymptomatic disease. Young adults don't really go to, primary care. The only reason why they probably would learn that they had high blood pressure was if they had another complication related to their blood pressure. And so a barrier could be a lack of realization of the long-term consequences. Yes, the long-term consequences of uncontrolled blood pressure among younger adults. It could be that, for instance, young adults don't perceive high blood pressure as being an issue of their age group. It's usually something we think of with older individuals. And if you feel fine, you probably don't suspect that you have high blood pressure. Someone mentioned it's an asymptomatic condition. But then, there's also from the food security due to lack of money, unemployed. All great things. Social, when you're talking about social determinants, we know that young adulthood is characterized by transitions in, in various domains. It could be in the career, with regards to family building, with regards to, a lot of people might still be in school. They, which in case your educational experience might not yet reflect in your income just yet. Lack of insurance with medication coverage. That's a great point. Lack of consistent medical follow-up. Also a great point. So with all these things in mind, and we know that education, would be an important factor. What role do you see the pharmacist in particular playing in this grand scheme of factors that we know, including social determinants, and not just saying education? Can we be a little more kind of finite in what those actions might look like? Anyone? Hearing nothing. Oh, that was my question. Sorry. So I'll give you some ideas here. Providing BP checks, offering education, referring to providers as needed. Community pharmacists can be highly involved in monitoring BP in the community. Establish agreements with clinicians to adjust medications. Early diagnosis. Agree with high. Great. And so, these are great responses. And so my question here was, what is the role of pharmacists in the interprofessional healthcare team to achieve blood pressure? Assisting with out-of-office monitoring, education, identifying non-adherence, resolving non-adherence, titrating blood pressure medications, B, C, and E, all of the above. And so it's basically all of the above. And actually, I have a shout out to, what do we have here? All of the above, yeah. So I have a shout out to our colleagues, some of the colleagues here on the call. This paper, Pharmacist's Role in Hypertension Management, a review of key randomized controlled trials, provides a great overview. And so I wanted to mention this here because there's expertise within our VCU community that speaks to this particular issue and the role of pharmacists. And so I'm going to go through some of the trials that were highlighted. And the first is CAPTION, which is a cluster randomized trial of a physician-pharmacist collaborative model to improve blood pressure control. And the intervention actually included primary care practices, which were grouped based on their low or high pharmacist services. And then, there was a medical record review and interview with the pharmacist, which consisted of, the medication history, assessment of patients' knowledge of their blood pressure medication, discussion of barriers to achieve blood pressure control, and creation of a care plan. And so education of parents regarding patients with regards to medication adherence and lifestyle modifications also. So some of the points that you all raised in the chat earlier with regards to education, working with primary care to create a care plan, of course, assessing knowledge, patients' knowledge of their blood pressure medication, and also addressing barriers to achieving blood pressure control are also parts of the conversation that I didn't hear in the chat that could happen with pharmacists with regards to blood pressure control achievement, in the community. In addition, so the results were clinically significant reduction in systolic and diastolic blood pressure, even though there wasn't statistically significant difference when compared to the control group. But clinically, 6 points of systolic blood pressure points of millimeters per mercury actually improves outcomes. Actually, even just 5 points decrease can have implications for future cardiovascular risk relates as identified in other studies. So that's a clinically significant amount, even if it's not a statistically significant decrease. And so there was a statistically significant improvement in blood pressure from 39 versus 18% comparing among minority patients, comparing those who participated in the intervention, 39% versus the control, 18%, and at 24 months, 36 versus 19%. And a second intervention actually examined, looked within the context of communities, barbers who are a trusted sort of community source for African-American men who have higher rates of hypertension, earlier onset, worse outcomes. And so this is an opportunity for, sort of practitioners to work with community entities and trusted entities to be involved in sort of peer-to-peer motivation. In this case, the initial intervention used role modeling stories of other clients, as well as barbers actually physically checking the blood pressure for all Black clients, and advising people to follow up with their physicians. In the revised intervention, though, pharmacists actually facilitated the blood pressure measurement, and changed, blood pressure medications as needed. And barbers encouraged clients to measure BP and follow up with physicians. So in this case, the pharmacists were actually working hand in hand with the barbers, and there were 4 intervention visits that included the pharmacist measuring blood pressure, reconciling medications, working with patients on goal setting and activation tools. That's another opportunity, working on goal setting and activation among patients that a pharmacist could take on, and prescribing and intensifying antihypertensive. And this study actually resulted in a 26-point decrease in systolic and a average 14-point decrease in diastolic, which is phenomenal. And 68% of the intervention group achieved blood pressure control of less than 130/80, which is consistent with the guideline. So I'll stop here, and because I wanted to give time for some discussion. I don't see anything in the chat, but Teresa, did you want to move forward here?
Yeah, I actually have a question. I would like to give the opportunity for people to ask questions as well. But in the meantime, while we don't see anything on the chat, I did have a question. So in your study, Rich Life, your cluster randomized control trial, you mentioned that everyone improved, but whites improved more than Blacks in terms of blood pressure control. And you measured patient activation. Were there, and I know you're still working on the results, but were there any differences in patient activation between Blacks and whites, and in what specific domains?
Right, and I want to be clear, because so the work leading up to Rich Life, actually, so the Rich Life study is still underway, so we don't know any of the findings from that. But the previous work, because Dr. Lisa Cooper has done a number of studies looking at, targeting cardiovascular disease, targeting hypertension, trying to improve. And that's where they found that kind of it lifted all boats, but there still remained a kind of disparity. And if you'd like, I can actually send that paper to you. But for instance, the hypothesis was like, okay, should we be thinking about patients, involvement a little bit more, which is why in the Rich Life study, one of the primary outcomes is patient activation, and looking at whether or not community health workers or involving with the more intense kind of arm engaging with nurse case managers might in fact impact both blood pressure control as well as those activational components, which we believe underlie some of the reasons that we might see some of these differences. Which of course happen within the context of these social determinants of health that people have to navigate in order to be activated. So treating really the behavior of the patient within the context of their surroundings, their social and physical environments is really important, I think, in overcoming some of these barriers to achieving control.
And are you using the PAM, the patient activation measure for
Yes.
patient activation? Okay.
Yes, we're using the PAM.
Okay. And then I was curious as well for the medication adherence with all this controversy around the Morisky scale. I was curious to hear what you guys are using in your study.
Yes, and so we are using the Morisky scale. And so, there will be interesting conversations had with regards to the findings and what exactly, there's actually another scale, the Lee scale is I think it's the Bone Hick scale, but another medication adherence scale we also have data on, because the Mirsky can be a little controversial.
Yeah, yeah. Okay, perfect. Thank you so much.
You're
Any
welcome.
other questions from the audience?
Yeah, I do have a question. This is Yusuf. So the question I have, this is just more of educational piece to me. So we've been focusing a lot on the patient and addressing the patient condition in terms of dietary changes, all the social determinants of health. From your perspective, and obviously from the work you're doing, how much has been done to address the providers in terms of
Right.
addressing the condition? Sometimes I was actually reading something published maybe a month ago, or even less than that, the discordance between guidelines and what the providers are prescribing. How do you reconcile that to get to patient to goal when in fact it's not the patient problem? Probably is just the patient is given the wrong medication in the first place.
Right.
Not
Excellent. I think that's an excellent point. And so I didn't kind of hone in on the systems aspects of Rich Life, but Rich Life is actually multi-level. And so we're actually looking at kind of on the practice level, what is required to bring in some of these health disparities programs, but also on the provider level and thinking about how we engage providers about taking on some of these things. Now, the issue of the guidelines is a whole new one, which I'm hoping to address in my PACE study. We're working with providers at VCU Health to understand what it takes to, kind of assess knowledge and attitudes towards the new guidelines, but also, what are the kind of levers related to the behavior of actually diagnosing and treating an individual, and what sort of factors guide the way people make those decisions. Because I think you're absolutely right that it involves a multi-level approach. And so oftentimes, like you mentioned, we do focus on kind of patients and what patients are doing, but there's a whole, another side of this that really involves systems levels change, which actually in some ways tends to be more difficult to achieve than behavioral change among patients. And so we're thinking about providers within the context of systems. So how do we provide on the systems levels, the environments, that could include, for instance, when we're going to do this pilot, engaging with practice level providers to figure out what, sort of environmental restructuring needs to happen so that individuals can, so providers can make the right decisions. Oftentimes what we feel, and I don't have results yet from our data, but in exploring the barriers that, providers feel like they don't have the time to do lifestyle interventions. They don't have time to do the education, that, there's no kind of benefit to the time invested in kind of, doing a thorough, taking time to do all the care planning and goal setting and all of that stuff that are really shown to be kind of evidence-based approaches to improving blood pressure in these groups. And so you're absolutely right. And I don't think we have an answer just yet. I think that when the findings from Rich Life come out, we'll know a little bit further, as well as, when I do some of the provider engagement with PACE to find out. But you're absolutely right that one, and in fact, some systems have not even been employing the new guidelines just yet. This is kind of, there hasn't been sort of a universal agreement that this is how blood pressure should be treated. And so we have a long way to go with the new guidelines, but we already had a ways to go under the old guidelines. But I saw you come off mute, so did you have something else to add?
No, thank you. I think I just wanted to concur to what you said. You're absolutely right. So I look forward to reading more about your work.
Thank you. Well, I wanted to give, I had my question about, and we didn't get any responses in the chat, but in thinking about the role of pharmacists in this plan, if we could just talk about what you perceive as barriers to engaging as pharmacists in that, grand scheme of things, I would love to hear from you all.
So I was hoping that some of the clinicians would speak up, but I can speak on their behalf. So we actually have some of our faculty work in free clinics and, with primary care, both at VCU Health and some free clinics and some other clinics for the underserved population. And we play a huge role in managing not just blood pressure, but diabetes, even smoking cessation, cholesterol. So a really multi-level intervention in providing comprehensive care. Pharmacists in those clinics are able to work under what it's called a collaborative practice agreement that they establish with a physician that's responsible for the clinic. And so they're able to initiate, modify, all the treatment associated with those conditions. So in the primary care level, we do play a huge role. Unfortunately, it's not widespread. And we have some of our research within the center is around really disseminating those models, implementing and making sure that, everyone in primary care who needs to see a pharmacist would be able to see one. We do have more touch points with patients, in titrating insulin. They come in more often. We're more aggressive in terms of how, in the dosage and how we treat them to address some of the therapeutic inertia that has been documented in both hypertension management and diabetes management. So a huge role in primary care. With in community, community pharmacists also have the ability to do that. Unfortunately, and we have some good examples of, community pharmacists providing services and immunizations and working under protocols for, managing blood pressure, but also administering or identifying any strep throat issues or prescribing oral contraceptives. So there's multiple aspects related to that vary across states. So the problem with community pharmacy is that these models are also not widespread. Some of them are very well established in California or Oregon with the legislation around statewide protocols and oral contraceptives, for example. And Virginia recently passed that legislation that will make pharmacists more active in managing some of the preventative and community and public health related services. So yes, we do have a long road ahead in engaging more with with the community, but there are structures in place. There are things that are happening, and it really just is trying to make it like a large scale and something that's institutionalized than an ad hoc intervention.
No, great, thank you. That's really helpful.
And there's some things on the chat.
Lack of time and ultimately reimbursement for care. Mm-hmm. Yeah, absolutely. I think that, we're trying to navigate those issues, that those are major stumbling blocks. So it's kind of, this interesting conundrum where you need to prove the value to invest the money, but you need the money to demonstrate the proof of effects. So, we're trying through, pilot studies, hopefully identifying processes and streamlining them in such a way that they do not impede on the workflow, and they kind of have people in professionals working, interpersonal professionals working in capacities that make sense for their roles. And, creating structures and systems of communication that actually, kind of keep that flow going, I think are going to be essential to addressing some of these things. And I wanted to address this other comment. Do you think academic detailing, one-on-one education could be a potential solution? I absolutely think that would be an awesome solution. Again, but I think that it's confronted by, again, these issues of resources, resource allocation, and time. We have to think about how we're managing time and, money. And so, if we can master that, I think we can solve the problem, but that's easier said than done. So we're on a path to that, though. I hope that when we're looking at some of these more community-based interventions and showing that there are really resources in the community, including pharmacists, that could perhaps help to fill some of those gaps that we think, okay, the primary care provider alone should be doing these things. No, well, perhaps we can get to community resources via pharmacists or community health workers or other community organizations that can provide some of the education, the care planning, all of the extra lifestyle modifications, sort of goal setting things that might be difficult to accomplish within the context of a 15-minute primary care visit.
Yep. Well, we are at the top of the hour. I really want to thank you, Dr. Hines, for spending this afternoon, the beginning of the afternoon with us and sharing all of your incredible work. We also have things going on at the Health Hub, so we're going to reach out offline to see how we can leverage all of our efforts.
I love that. I would love that. I am all about interpersonal collaboration. I would love to have more pharmacists involved in this very important issue and at the Health Hub. So please, that would be great. Thank you all for your time.
Thank you so much. And everyone, if we don't see each other before then, happy Thanksgiving and hang in there and let's make the most of it and just enjoy the family, even if it's virtually.
Thanksgiving.